they need. My name is Sally Traore Ualaka. I am a pharmacist. I'm a clinical pharmacist specialist, and I am now affiliated with Howard University and the College of Pharmacy. And I'm presenting today with.
My name is Amanda Fringer. I am a certified pharmacy technician, and I'm workshopping a new title, but currently I am a medication access technician, helping patients get access to their medications prior to discharge from our hospital.
Yeah, thank you so much. You can sit, and then I'll call you up. Yeah, so our presentation today is really focused on our desire to share our success with what really, in its classic definition, was a pilot program. As we were going along and building this access program and building this service for the patients in our community, we adjusted along the way, made connections, collaborations to try to bring it to fruition. But in essence, we wanted to share the impact of this pharmacy-led program and its improvement or access from brand medications for what we predominantly saw in our clinic as Medicare beneficiaries. My objective here today, and Amanda's objective, will be to just help understand the social determinants of health and its direct impact on patient outcome. And then understanding our clinic's approach in addressing what the challenges we were facing that were essentially just access barriers that were specific to medications, and then outlining our process. So what we designed and what Amanda and I worked on and tweaked along the way that helped us get the amazing results that we were able to secure for our patients last year. I really wanted to kind of gauge everyone in the room to see just who I'm talking with, really. But which of the following most accurately describes your current practice? And we're going to get very fancy. You're just going to raise your hand. My practice site has multidisciplinary approach to resolving medication access barriers. Raise your hand if you can identify with that. Okay. And then my practice site has a pharmacy-driven access barrier program. Very good. And then access barrier is a one-person army endeavor at my practice site. Oh, yay. That makes me really happy. I just don't want anyone taking it on by themselves. The access barrier program at my site includes pharmacy technicians. That's awesome. And I'm in a practice site where we don't have an access barrier program. Okay, very good. So it sounds like everyone here to some degree has a program where you're currently working that's trying to address this. That makes me really happy. And I wanted to start with this, but you've probably heard this. So as a pharmacist, a lot of the intellectual exchanges I have with providers, it's like a balance between personal feelings on medication access, but also evidence-based medicine. The most effective therapy is the one the patient can afford. I am categorically opposed to that statement. So as a pharmacist, everything I do is evidence-driven. It's based medicine. Oh, yeah, that's what you meant. So everything I do is evidence-based medicine. The decisions that I make and the recommendations that I make and the things that I fight for my patients, I have guidelines and literature and things to really drive that conversation. So when I hear someone tells me that the most effective therapy is the one the patient can afford, immediately I'm like ready to fight. The second thing is medications do not work unless you take them. Fact of life, fact of science, fact of common sense, ethics, all the above. And where access barrier lives currently in the healthcare system is somewhere between these two things. There are folks who believe that I'd rather put a patient with heart failure on lisinopril when I know that that's a $4 copay generic. It has mortality benefit evidence instead of fighting to get the patient on Entresto where the evidence is stronger for that in that patient population. Social determinants of health, the World Organization does in fact have an official definition for what it is, but it's essentially a series and a host of different things that where someone lives, works, play, and worship and their age, it affects a wide range of health functioning and quality of life outcomes and risk. they've gone a step further to isolate all of these social determinants for us so that depending on what your targets and what your goals of outcomes are for your patients, you can actually target one or all of these different areas. But we have economic stability, education, healthcare access, but also the quality of the healthcare that they have access to is important. The neighborhood and the built environment, and then of course their social and the community context. So its impact on health, you can see here that overall we have where people work, their income, their debt. I just attended a talk on financial toxicity, but the burden financially of maintaining or even being able to meet their health goals plays a significant role in their mortality and life expectancy. And the place where we, as a health system at Carroll Hospital in Westminster, Maryland, were finding ourselves were that pharmacy providers' healthcare coverage, linguistically appropriate education, culturally appropriate education, these were having a huge impact. And patients were presenting to the emergency room for preventable medication-related issues. That is simply if we were able to do something related to their medication, that emergency room presentation could and would have been presented. And so we decided to develop a process to target those patients. We get into what's called cost-related medication non-adherence, and it's exactly what it sounds. It's just that how much it costs, the financial responsibility and burden on the patient is having a direct impact on their ability to meet their health goals or lack thereof. And the process of resolving that has long-term, was to develop a process to addressing that and being able to demonstrate its benefit, not just in the immediate, but also in the long term for patients. A little background about Carroll and who we are. 1961 hospital. It is in rural Maryland. It's right outside of Baltimore, so it's a little difficult to understand that it's rural, but it is. It's a 168-bed nonprofit hospital, and it's a very geriatric focus and centric hospital. And what this immediately translates into for us is that most of our patients are Medicare beneficiaries. Our clinic. So I think the clinic turns 10 this year. It was started by a pharmacist, but its focus, its drive, and its number one thing is developing strategies and processes where we are becoming better at identifying medication-related issues and then resolving them before the patient leaves in order to prevent admissions and or readmissions. The clinic has over 92% combined underserved population. These are government-insured patients. And there were 5 of us, 3 technicians and 2 pharmacists. The internal medicine transitions of care program is an integral part of our clinic. In the inpatient setting, there is another PharmD who is really our direct partner. She's very instrumental in helping us identify high-risk patients. And high risk in this sense are just patients that we've identified based on the hospital's report as healthcare resource utilizers. So the heart failure patients, the COPD, the anti-coag patients, and we usually group them together, those on DOACs as well as warfarin, and the diabetes patients, but we're particularly interested in diabetic patients who are on insulin therapy because we know hypoglycemic events tend to be the number one contributing factor to bringing those patients back to the hospital. So educating them on appropriate insulin therapy is important to the clinic. The Access program has 2 arms. We have a voucher program where we essentially cover copays or pay for medications through money that's set aside by the pharmacy department for patients that are admitted and they cannot afford their copay at time of discharge. This is to help that all issue of I don't have my copay and I can't afford the copay when I get to the pharmacy. So we have a voucher program that we run in conjunction, and then we have a very targeted program for brand medications that we are here to talk about today. The brand medication access program focuses on two things. Number one, we want to make sure that when these brand medications are started at admission or inpatient, that the patient has a 30-day supply of the medication before they leave, and that we develop a strategy on how we can get them into a long-term plan so that they are able to continue to remain on therapy thereafter. In 2018, that's really when the clinic's journey, or we have the earliest data on patient access services being provided in our clinic. In 2019, when I took over clinic, I began collecting data in a more targeted way. And in that year, we had a documented 60,000 saved to patients in our community. In 2020, that became 72. And in 2021, we went up to $500,000. And the biggest thing that happened here in this consistent growth that we were observing in our clinic and our success was our ability to recognize who the patients were early improved each year. We started talking to case managers, social workers, even the providers to tell them, if you're seeing patients with X, Y, and Z, please refer them to us. We're happy to triage and see if there's anything we can do to assist. That was the biggest intervention we implemented between 2019 and 2021. The program's design really was, again, identifying and resolving medication access barriers to patients that were admitted to Carroll. A very important point is the focus of the program is on patients going home for two reasons. There's a patient education component that's baked into this, and it targets patients going home because these are the patients that leave the hospital and go back home where they themselves are responsible for their drug therapy. So educating them on medication safety practices and all of the resources available to support them was a big intervention for the program. And if the patient is going to a facility, the Medicare billing is different. So we don't really have to worry about Part D coverage for the drugs in that instance. It is retrospective, all of what we saw here, we prospectively intervened. This was a single center. Carroll is part of a system, but this was just an intervention at Carroll because presently Carroll is the only hospital in the system with such a program, and patients were not randomized at all. From January to December of 2019, and we included discharges home and excluded discharges to facilities. We built a list based on our 2021 report when we saved $500,000 to see what were our top medications that we were having patients face challenges for, and what were the top medications that we were having successful interventions on to build the process. And these medications really are our top performers. And again, if you look at it, our population, they're elderly patients. So Brilinta, Eliquis, Xarelto, they're like our top three always. And deficit with C. diff and antibiotic utilization and the inhalers. And then you have the breakout stars of 2022 being Entresto and Jardiance. Our hypothesis was simple. We hypothesized that with a proactive approach in really targeting patients to identify them who needed cost assistance will in fact result in positive outcomes and in the form of saving the patient's money, and that outcome could be sustained beyond just the mighty 30-day readmission period. The referral process was simple. The inpatient provider places an order for one of the medications on the list. So we say Jardiance or Entresto. That triggers an automatic alert for the pharmacy. This goes into a queue that everyone on our team has access to. The pharmacist as well as the technicians can see that a new order for Deficit or Entresto or Zyvox has been initiated. And then one of us, depending on our workload that day, it is assigned, triages each, and then we start developing an access plan. That plan then begins with a direct communication with the internal medicine pharmacist inpatient to make sure that they know that we've seen the referral, we are on it, and we will be communicating what the discharge plans will look like. This is just a visual representation of what I just went over for the visual learners. But the other thing that we did in 2022 that I think made a huge difference is we built our referrals in for these medications and made it a field that providers couldn't click off. So if the provider orders Eliquis or they order Entresto, they may not even, some of them have no clue that it triggers a referral to us, but we are right there at the bottom as a baked in referral that they cannot opt out of. That really took the power out of their hands and our chances of missing patients. Because when we receive the referral, we can triage to say, oh yeah, we know him, he's good, we saw him 3 months ago, all of the stuff is lined up, versus this is a new start, we need to start from the beginning. Once the referral is received, this is what the order sentence actually says, and you're able to look at it very quickly and see that the drug ordered or your referral is Eliquis. I'm going to have Amanda come and describe the technician workflow for us at this point. Thank you.
Hi, everybody. So our tech, it really, so it is very much like what Sally was just explaining. So we start with getting the medications. This is our queue, like she was speaking of. So the medications come in as in our task list. So through our Cerner, the description tells us what medication we're looking for this patient. As we're going through and trying to triage those things, we're looking at things like the patient's disposition to leaving. Are they leaving soon? Do they have an antibiotic that is something that they need? That's something that I'm going to triage closer to doing it first versus I'll hold off on an Eliquis for a patient that's going to be here for a couple more days. So those sorts of things are where I'm looking to triage what I need to work on first. So with this also, not only are we getting these referrals from this automated triggered system, our floor pharmacist in our hospital. So each floor through the week has a pharmacist that sits in on rounds for the patients. If they have something that triggers an interest for them that they think we need to be aware of, they will manually send us a referral, as well as the case manager. Same thing. Case managers are designated for these patients. If they are getting information from the patients that make them think that we need to be in contact with these patients, they can also manually send us a referral for these medications. So the first thing that I'm going to do after I've triaged who I need to work on, I've selected a patient and I know what medication I need to look for. The first thing I'm going to do is identify what insurance this patient has. So I want to make sure that the patient's insurance information most of the time is coming to us through their registration. When they're in the ED, as they're being admitted, through their admission registration, that most of the time that registration information, we can pull it up and find what their Part D coverage is or their Medicaid, and we can get that information right from our EHR. So the next thing would be finding, so as we're finding out what their insurance is, it's going to tell me what my next steps have to be. So if a patient is uninsured, I have a set of steps that I'm going to follow there. If they're commercially insured through a self-pay or through their employment, then again, another set of steps. Government insured, that's our wheelhouse. That's where we're living most of the time. So determining that coverage is our first step in our technician workflow. So my job as a technician is I want to make sure that these patients, if it's a new start, I want them leaving with a 30-day supply of this medication for 2 reasons. One, it gives the patient peace of mind. They've got this medication. The provider has given it to them. They're walking out of the hospital with it. They don't have to stop by the pharmacy on their way home from the hospital. They don't have to do any of that. Second reason is it gives me a 30-day cushion to take the next steps on where this patient needs to go, applications they need to fill out, community resources they need to be in touch with. So that gives me and the patient a 30-day window to get those things in place. So if they're uninsured, so you can see in every situation, regardless of their insurance, everybody is eligible for that free trial card. So the uninsured folks, so we're going to leverage that free trial card. We're also going to, if it's something that is not a brand name medication, but maybe this patient is unhoused and they can't afford their copay. Again, that voucher program that is set up at our hospital, we have some pretty strict guidelines of where that person, they have to get approval for certain things. The boundaries that our director has set is any medication that is under $50 for one medication, or any set of medications that are $250 or less can just kind of go through with some sort of appropriateness. So we're not just doing this for everybody, but certain criteria have to be met so that we can get that voucher program for these patients. So again, if they're unhoused, they're on their generic medications, and we're hoping that they aren't readmitted. Commercial patients, those are the ones that we love because they're so easy. We get them that free trial card. 9 times out of 10, I will call the pharmacy, their community pharmacy, because I can also see their fill history, and I'll give the community pharmacy the processing information for the copay assistance card. I will give them that information. I tell the patient that they just have to call and activate the card, and you'll be all set. And then after that, they are good until the next year when they just need to re-up with a new card. So the voucher for that is, again, things that are secondary billing for like generic chronic medications, that sort of stuff. So we're trying to get them their 30 days, whether it be free trial card or through the voucher. So if the free trial card, let's say a patient this is a continuing therapy for them, and they've already used a free trial card, whether it be 2 months ago or 2 years ago, that's a once in one lifetime use for those. So at that point, we would leverage our voucher program. For our brand name medications, we try to avoid that. But we can, a couple of days, again, it gives us that cushion. We can provide them with a couple of days supply to get them this medication so that they can be discharged with something. So then the next thing that is obviously most important to me is that we want to make sure that after this 30-day free trial is over, what do they do next? How do we make sure that this medication is going to be available for them for the long term? So we want to make sure that they're able to get this in a financially motivated way that is appropriate so that they can continue to take this medication because it's going to be best for their treatment. So after determining their insurance benefits, the first thing that I would do after getting them the access to the medication prior to discharge is I want to make sure, I want to call their insurance. I'm on the phone with their insurance. I'm seeing what the coverage is, where they are in their deductible. Are they in the donut hole? These are all questions that I am asking these representatives from these healthcare providers or from the insurance companies. So as we're getting that information from them, it helps me determine what is the next step for this patient to get this access for the long term. So uninsured patients, a lot of times we're going to first work with getting them into a manufacturer's PEP program. So the manufacturer's PEP program is going to allow this patient to get this medication for free every month from the drug manufacturer. They have some qualifications that are income-based, and I think one of the options is that you can click that you're uninsured. So that is our first step. If it's something that is appropriate with a GoodRx card or the Mark Cuban Pharmacy or any of those online-based assistants, those we can also give them that information, provide it to their community pharmacy, and it'll help to bring that cost down versus just a self-pay. Access Carroll is a community resource that we have in Carroll County. So Access Carroll is like an integrated community service. So it provides income or care for these patients that are uninsured or underinsured, and it's making sure that they're getting an integrated assistance or like continuity of care, if you will. So they are a volunteer-based program. They run on donations, and they will help these folks that are uninsured to get access to some of the brand name medications. They will also help them with the prescription assistance program. We normally put it in the patient's hands, and then Access Carol can also help them complete that prescription assistance program application. So next would be our commercial insurance. Again, that's pretty straightforward. We're leveraging those manufacturer coupons. We have a really good relationship with a lot of our drug reps. They're coming in, they're talking to us, we're getting the manufacturer coupons, we're telling them when we need more. So they're a big help for us with our commercial folks. So the third is going to be our Medicare folks. So that's going to be, again, a lot of our patients in our community are going to be these Medicare folks. So with Medicare, the ultimate fix is going to be our extra help or the low income subsidiary program for those folks from Social Security. So with that program, if they qualify for that through income and assets and household size, that brings their medication, any brand name medications, down to for 90 days, a $10.35 copay, which obviously is fantastic. It helps absorb some deductibles and all of that sort of thing as well. So it's really, that's where we really want the people to be, in that low income subsidiary. Also, the patient assistance programs. As people are falling into their donut hole, they start to tip into the, they've paid that 3 to 6% that the manufacturers are looking for to have these patients be eligible to receive this medication for free from the drug manufacturer. So then to help get them through the end of the year, so they're not paying to get out of their donut hole. Lastly, we have our Medicare folks. So the Medicare folks, Medicaid, a lot of times that's just leveraging a prior authorization. Prior authorizations for these brand name medications for these folks on Medicaid is Medicaid wants their information up front. They have all of these medications on their formulary, but they want that information of why these patients are being prescribed this upfront versus having to collect all that information at the end of the year. So a lot of the Medicaid is just working with the provider in-house, or a provider that the patient is seeing for cardiology or their PCP, to get these prior auths completed. So again, our decision-making process. Does the patient have prescription insurance? If yes, we want to know what they have. Do they have Medicare or a government-funded program? Do they have commercial or private insurance? After we make that determination, Medicare, we're going to go through our channels to see where they are in their deductible, where they are in their donut hole, and get those programs started. For the extra help through Social Security, in Carroll County, we partner with our SHIP, the Senior Health Insurance Program. So the Senior Health Insurance Program is at the Department of Aging and Disabilities. Our contact there is wonderful. We give the patients the information, we give them to her, and then she helps them decide which programs are going to be best based on their income and their eligibility requirements. The extra help, she's also explained to me, like there are a lot of other things. Like, everybody thinks that if you're not eligible for this extra help, it's like there's nothing else that we can do. But there are a lot of other Medicare programs that are savings programs. She said there's one that it allows the patients to have one out of their open enrollment period, they can change their plan. So if somebody has an episode and they are now on a new brand name medication, but it's in April and they didn't have this brand name medication when they applied for and got their Medicare plan for this year, this program will pay up to $60 for their monthly premium, but it also helps them to pick a new program, a new Medicare program out of their open enrollment window. So an example of that would be somebody has an Entresto and it's a new start. So they don't qualify for extra help because they've saved their whole life and now they have too many assets, right? So the other program that she was telling me about, it will allow them to, now they can pick a program that leverages a little bit better the cost of the medication, but maybe the monthly cost of the plan is a little higher. So it's going to kind of balance that out. But if the program is going to pay $60 towards your monthly cost of the plan, but your medication is cheaper, and that one doesn't take into account any of your assets. It's just monthly income or gross income. So there are a lot of things, and working with Kristen at our senior health insurance program, she's really great. So next, the commercial or private, again, pretty straightforward. We're throwing coupons at them. If the patient doesn't have insurance and they're self-pay, again, depending on what the medication is, we're going to use those community resources. We're going to have them reach out to Access Carol. We're going to get them the options to get an insurance if that's something that they're looking to do. We're also going to try and get them into their patient assistance programs through the drug manufacturers so that they have that whole year to help get on the right track, whether they're getting an insurance, and we're moving forward with that.
So all of these processes that we're following, and the thing that I think is really important to mention as I get into the results of what we did last year, the biggest difference that we experienced in clinic is we gained Amanda, Christina, and Tina. I found myself with 3 technicians when in 2019 and 2020, I was doing the access by myself. So these results are impressive because it took a collaborative effort, and having technicians that had extensive community pharmacy experience and spoke and understood that language. In essence, there were over 2,000 interventions we saw in patients with access barriers that were referred to our clinic. 33.3% of those referrals were folks that actually needed pharmacotherapy assistance, continuation of therapy. They were not getting started on anything new. But the majority of the folks we helped were really new starts, patients coming in and or being initiated on one of the drugs we showed earlier, and they were brand new for the patient. And what we found is that almost 90% of the patients were government insured patients of these 66% patient. Our uninsured population is low, and Access Carol handles the volume really, really well. And our commercially insured folks, we would love for that to grow. But where Carol is, it's no surprise that we are really living in that Medicare, Medicaid space because of the average age of our cohorts. Our primary result was to demonstrate how much the program saved patients. And in 2022, we were at 1.3 million, up from 503,000 in 2021. And this is over 93% reduction in patient out-of-pocket. That's what I find incredibly impressive, because what this essentially means in simple terms is if patients were paying $20 for a medication, we were able to take away 17 of that $20 almost from them, and they were only paying about $3 to $5. And the patients are very appreciative and finding out that we will do all the running around for them. Like, we take forms to their homes to sign it. We take forms to provider offices. It's Amanda calls it God's work, but we're really just not staying within the descriptions of our roles because we see the patients come into the ED. And I always like demonstrating this graph because it kind of tells us a story about how we're using the patient assistance, the vouchers, and the coupon. That March season is usually when people are starting to realize that we exist. We get this huge explosion in clinic volume around March, and we capture all of them, and the outcome recordings will start to kind of trickle down. What you're seeing in November and December is that the patient assistance program is only going to give you coverage through the end of the year, December 31st. Patients have to renew. So our savings here is just 1 to 2 months. But this April to October window, this is where technician assistance was most critical. That's number one. January to June, I was a one-woman army. This was all just me by myself. And in July, I gained Amanda and the 3 technicians, and they added this. And what's interesting here, of the $1.3 million save, almost $800,000 of that came in after the technicians came in. And the reason why I think it's important to mention that is because the technicians' impact and the success of this program cannot be overstated. Someone had to build out the process and all of that, but their diligence and their passion for really pursuing and staying with these patients is how we're able to share the results that we saw in our clinic. And look at these 30-day readmissions. There's no other program in the hospital performing like this, where we're seeing cohorts. Our monthly referrals in January were like 170 patients that we intervened on, and only 4 of them returned. And the 4 people that returned, when we did subgroup analysis on all of these readmissions, not one was medication related. Right? So our hypothesis was 100% supported in that our ability to identify the patients early and appropriately and then intervening on them effectively absolutely is making a difference in the patient's healthcare resource utilization and justifying the need of having technicians in clinic with us, skilled technicians. In 2021, when I was doing this on my own, I was only getting 37.8% by myself with brand medication utilization. And after the technicians came in, we went from 37 to 82.7%. Again, the impact of having that team-based approach, the technicians are able to call the social workers. Like, my phone is like, I have the providers blowing me up for pharmacists, like my traditional role services. They're asking for recommendations. They're asking for dose adjustments. I'm carrying out those clinical services while I'm working to try to get the second piece of it, which is securing the patient's access. Once I got the technicians, we were actually able to clearly delineate, while I can focus on the clinical services, the techs can focus on the access. Key takeaways that we really wanted to highlight is the multidisciplinary approach is crucial to the program's success. It really took everyone. In some instances, we had community pharmacists that were faxing us patients' accurate home med lists because they were like, that's not all they're on. And they haven't filled this in 3 months. They haven't filled this. So when we explain to people why we're reaching out to them and what we're doing, they're eager to engage and help us. So we haven't suffered in that sense. Access barrier must be assessed as part of the pharmaceutical care plan. And this is where the integration with the internal medicine pharmacist proved really, really valuable because she's able to kind of see the patients early. And if there are conversations happening at admission day number 1 to initiate insulin, to initiate a different inhaler, she taps us in before the order is placed. So we're able to start working on that patient before any decision is made that the drug will be started. So once the drug is started, she's on the phone with case management. This is what I know. This is what I know. Here's what we're going to do by day 3 when the patient gets home. Pharmacy technician to assist in designing the plan is crucial. I really wanted to make that a third takeaway. I would not have been able to do any of it without the assistance of such stellar technicians with extensive knowledge. And really, I think it goes back to that caring spirit. They are interested and they are passionate and they believe in what they're doing. And it reflects in all the work that they did. So I'm just incredibly proud of that. And thank you. We can't wait to see you here, but we're here. If you had questions and wanted to contact us, we will take those at this time, but we wanted to include both our emails on there. Let me know if you want to I'm on LinkedIn as well.